Hi, my name is Dr Gerancher, and I would like to share with you 4 suggestions for a program of regional anesthesia. These suggestions were the ideas that made regional anesthesia at Wake Forest University work and help it grow from a few faculty with an interest in 1999 to an academic section with a newly constructed regional area in 2009. Maybe they will work for you too. Suggestion number 1. Attraction rather than promotion. If you are sitting here, you likely believe regional anesthesia improves all kinds of outcomes for patients. Problem is, many surgeons remain unimpressed, perhaps by actual experience. Rather than promoting regional for specific patients or specific surgeries, we sought only to attract, and only to do so for a handful of surgeons, those who are already attracted to regional anesthesia. We dedicated all our resources to a list of surgeons and treated only their patients. This list grew when new surgeons opted in. Not everyone agreed with this approach. Occasionally, an anesthesia colleague would insist on a block for a sick patient of a surgeon that didn't especially care for regional. In my experience, making these exceptions did not help promote the program and never attracted a surgeon. Suggestion number 2, be fully self-supporting. You likely believe regional anesthesia is cost-effective and saves tons of money. Problem is, most hospitals do not employ an administrator responsible for specifically measuring this. Hospitals do tend to have silos of people fretting about cost. So when we started, we tried not to spend a lot of money. Our first regional cart was from Sears and I painted it in my basement. We found we had to negotiate aggressively with our billing compliance office even to allow us to bill effectively. And of course, we had to make sure anyone doing a block knew how to write a note. Computers helped us do this. Suggestion number 3, principles before personalities. Every anesthesiologist who does regional surely loves doing blocks, but we soon learned we couldn't each do what we each wanted. Our regional program didn't work when I placed an epidural for a total knee on Monday, but my partner used a femoral catheter later on that week. We had to operate our program like Henry Ford building Model Ts. You can have whatever color you want as long as it's black. Every procedure and every type of patient needed its protocol or algorithm. This takes a lot of discussion and planning, but does encourage evidence-based medicine, reproducible expectations, and therefore results. Remember, you're producing a product. Suggestion number 4, have but one primary purpose. Building a regional program is a lot like being our friend here, Sisyphus. He was the mortal who so cleverly outsmarted the gods, his eternal soul was condemned to carry a rock up a hill, only to have it slip from his fingers upon reaching the top. Then he had to start over again and again forever. Building a program is for sure hard, and it is for sure repetitive. Every day a new set of ORs to start on time, and every 2 years a new hospital administrator moving around our deck chairs. The difference is important. Moving a rock from point A to point B is pointless, and regional anesthesia is not. Materials can be viewed, I can be contacted or followed using your digital media. Thank you.